This is Patricia Munoz. I'm the head of clinical microbiology and infectious diseases in Hospital Gregorio Marañón in Madrid. It's an honor to be here. I'm full professor in the Complutense University of Madrid, as you can see in my image. So welcome to our webinar, Antifungal Resistance in Candida and Aspergillus. Is the honeymoon over? So let me first introduce ISAC. The International Society of Antimicrobial Chemotherapy was founded in 1961 and is indeed a federation of affiliated member societies. It aims to increase the knowledge of antimicrobial chemotherapy and to combat antibiotic resistance around the world. Currently, it has a worldwide membership composed of more than 100 national and regional societies, which in turn have more than 60,000 members. It hosts the International Congress of Antimicrobial Chemotherapy, ICC, every second year. The next one will be held in Istanbul in November 2024. We wait you there. So let me pass the microphone to my colleague, Abs Bal from the University of Glasgow. Abs, please.
Hello, everyone. I am Abhijit Bal, microbiology consultant at the Queen Elizabeth University Hospital and also the head of service in the same department. I am an honorary clinical associate professor at the University of Glasgow and the chair of the Fungal Infection Working Group of ISAC. Without spending too much time on myself, I'll introduce the first speaker. And the first speaker is Ana Alastruey-Izquierdo. She's a research scientist at the Mycology Reference Lab of Spain, where she leads the molds unit. Ana chairs the technical expert group of the Fungal Priority Pathogen List by the WHO, obviously. She's a member of the Scientific Advisory Board of the Joint Program Initiative on Antimicrobial Resistance and is president of the Spanish Society for Mycology. Ana is also a fellow of ESCMID and a fellow of ECMM, which is European Confederation of Medical Mycology. Ana's main interests are public health mycology, antifungal susceptibility testing, and surveillance and characterization of antifungal resistance. She has published more than 170 peer-reviewed articles in scientific journals, including several guidelines for diagnosis and treatment of fungal infections. Today, Ana is with us, and she's going to talk on epidemiology of fungal infections, with a focus on antifungal resistance. Over to you, Ana.
Thank you very much. My role today would be to try to guide you through the epidemiology of fungal infection, mainly focusing in antifungal resistance. So I always start with, as I'm the first one, I guess this is like an overview of where we are and the burden of fungal infections. We don't really know the real burden, but the estimations that have been published recently at the beginning of this year by David Dennis said that fungal infections kill more than 3.5 million people and affect over a billion people worldwide. You can see here there are differences between different species of our infections, and I will guide you through some of these epidemiological differences. So one thing that is important is that fungal infections are very broad, and most of you would know that all this burden is not only affecting immunocompromised people, so the host is very different. We can have superficial infections with us, probably most of the burden of fungal infections, and we have fungal keratitis, vaginitis, dermatophytosis. So this is usually affecting normal people without underlying diseases. Except for the primary pathogens as Histoplasma, Cocci, Paracocci, which I would not discuss today, which can affect people without any underlying disease, but cause invasive disease. The rest of them are mainly superficial infections. But the most important ones are the ones that are in patients with other health conditions. And this could be cancer patients, HIV, but also others like TB, COPD, and patients affected with viral infections, as we learned with flu and COVID. And the importance of this group is like the mortality is very high. It's true that the burden of disease is probably not as high, it's of course not as high as with bacteria, but we are dealing with mortality rates which are unacceptably high. Even with susceptible species, we are reaching mortalities around 60, 70 in some species, as you can see here in different infections. So compared to other diseases as malaria, TB, or HIV, of course, the burden is lower, but the mortality is very high. And as we are going to talk about epidemiology, this is just an example that talking about the epidemiology of fungal diseases is very complex because it depends a lot in this host that we were talking before. So depending on the type of patient that is suffering these infections, the epidemiology is completely different. And you can see here a very nice review recently published by Mohammed Mahmoud, but you can see here that for example, in solid organ transplantation, these are the most frequent pathogens. Of course, always Candida and Aspergillus are the most frequent, and I will focus my talk on that. But there are other infections by Mucor or Fusarium or PGP or Crypto that are also important in some infections. And in addition to this, we are facing another problem, which is the rise in antifungal resistance. This paper published by Matt Fisher in 2018, it's still valid, in which you can see which are the number of papers that have been published in the last years in 1977 regarding antifungal, which were reported antifungal resistance. And you can see from 1977 to 1997, it increases. And if you see up to 2017, the number of countries and the rates of resistance has increased a lot. With this problem, the WHO released in 2022 the fungal priority pathogen list, taking into account that the fungal infections are rising, but also especially because of the rise of antifungal resistance in several of these groups. So the focus today is going to be mainly, as I was saying, Candida and Aspergillus. That has been, and this is also a very nice review in which you can see how the epidemiology has shifted in the last years, changing to species that are intrinsically more resistant or secondary resistant, and maybe Jesus will discuss a little bit more in this later. And one of the things focusing on Candida, you can see here, and this is also a paper published by Jesús Guinea, the next speaker, you can see how the different epidemiological studies, population-based studies, you can see how the number of Candida albicans, which is in the left part of the screen, you can see here how the green lines are decreasing whenever the year is increasing. So this is a population based in Iceland, here in Denmark, in the US, in Spain. You can see how Candida albicans decreases, and the other species as Candida glabrata or Candida parapsilosis are increasing in proportion. And why is this important? Because as you can see in the other side of this slide, Candida albicans is usually susceptible to most antifungals in this traffic light graph, while Candida glabrata, for example, has higher MICs to azoles, or Candida parapsilosis has higher MICs to echinocandins, and we will also discuss later about Candida auris. So this is another review which is also very interesting, in which you can see again Candida albicans is the blue part, and what you can see is we are around 50% are usually Candida albicans, but we have to deal with the other 50%, which is now different species. And this is a very nice graph where you can see how the antifungal treatment changes and affects completely the epidemiology. So you can see here a patient with no antifungal prophylaxis. So the patients with no antifungal prophylaxis, most of the infections are with Candida albicans. Whenever the prophylaxis is more than 7 days, you can see how the number of Candida albicans decreases, and you can see other species. And if you look at the different antifungals, whenever you use fluconazole prophylaxis, with the Candida glabrata, which we saw has higher MICs to fluconazole or other azoles, is increasing in proportion, while when you use caspofungin prophylaxis, you can see the number of Candida parapsilosis and Candida glabrata increases while the other species decrease. So it's have a clear impact. Also, when we talk about epidemiology, the most frequent species, as we say, is Candida albicans, almost in most studies, but the second species changes a lot. In Europe, Northern Europe and the US, usually Candida glabrata is the most frequent species, while in, for example, South America and also countries like Spain, Greece, we have Candida parapsilosis as a second most frequent species. And other regions in the Southeast Asia, for example, Candida tropicalis apparently is also generating a problem. And this, it's in addition to Candida auris. You can see here the places where there is this dot is countries in which Candida auris has been reported. And as most of you would know, Candida auris is a new species that was reported only in 2009, and since then there has been reports of antifungal nosocomial outbreaks that are very important because they are difficult to identify, especially at the beginning. Now we have more capacity, but mainly because they has a susceptibility profile which is very resistant at so high MICs. You can see here from Europe, this was a surveillance by ECDC, and as you can see, different countries that reported Candida auris, and here Spain and England and the UK are green because there has been outbreaks in these countries, while other countries reported single isolated cases. But now we have, this is outdated, now there also have been outbreaks in Italy and in Greece and in several places. And you can see here how the number of strains has increased. And as I was saying, they are usually very resistant to antifungals, despite not having clinical breakpoints for all of these antifungals. You can see that it was considered intrinsically resistant. It's not intrinsically resistant, but most isolates are resistant to fluconazole, but also half of them to other azoles, a third to amphotericin B, 7% to echinocandins, and 41 have been described as multi-drug resistant, having been the first Candida which has pan-resistant isolates. So there has been several reports in which strains that are resistant to all antifungals have been isolated in clinical samples. I won't go into this, but there are several clades. Actually, this paper was with 4 clades, but I think now we have already 6 that have been raising in several parts of the world at the same time. So these specific pathogens, there is the hypothesis that has been linked with the global warming. So the global warming has probably pushed this species to adapt and to become a pathogen. Another important pathogen taken into account with the focus on antifungal resistance is Candida parapsilosis. As we were saying before, Candida parapsilosis has intrinsically higher MICs. We cannot say resistant because the breakpoint said higher, but higher MICs to echinocandins. And in the last, you can see here the proportion of Candida parapsilosis in invasive Candida infections in this map. As you can see, we were saying before, Latin America and the South Europe usually have higher rates, but you can see here other countries in Africa, in Asia, which also report in higher countries. And the problem has been that lately, since 2018, 17, 19, we've seen an increase in the reports of fluconazole-resistant Candida parapsilosis. And here you can see the higher than 10%. And in 2022, you can see how this was increased. And here you see what are the prevalence of fluconazole-resistant Candida parapsilosis as well in different countries. And again, you can see several countries which their antifungal resistant or fluconazole resistant rate is quite high. So this is, from my point of view, another rising issue in antifungal resistance in Candida. And the third one I would like to touch on is Candida glabrata. There were several reports when we started to use routinely echinocandins. As you know, echinocandins are the main agent, the first choice to treat candidemia. there were some reports that were saying higher rates of fluconazole, or in general, sorry, echinocandin-resistant Candida glabrata. You know, now we love to change name in microbiology, and Candida glabrata is now Acaciomyces glabrata, but I won't pronounce that one. I will keep it as Candida glabrata. And then there were several reports in which they were seeing higher rates, some of them reporting 10%, and this was linked with also higher resistance to Candida glabrata. I think that has not been still raising. There are some reports, but I don't feel, or I don't see that in the literature that there's the current most hotspot in antifungal resistance. But we did see in this publication, we saw different patients in which we saw how patients treated with echinocandins for a short period, like less than a month, they develop for a susceptible isolate, they develop resistant isolates with this specific mutation in the target. So these three things are important in candidemia, in epidemiology, and antifungal resistance. It's Candida parapsilosis, rising numbers of fluconazole resistant Candida parapsilosis, Candida auris, and also could be Candida glabrata. When we talk about Aspergillus, here we know that Aspergillus is in a different pathogen because it's completely all in the environment. We breathe Aspergillus spores all day. So actually this is why it has been highlighted as a One Health problem, specifically because fungal pathogens or fungal species are mainly pathogenic to plants. So fungicides are used worldwide to protect crops. So we've seen that the use of fungicides in agriculture has been linked with the increased rates of antifungal resistance in Aspergillus fumigatus, an environmental species which is in the air. So, and you can see here two very now classic, I would say, reports from 2009 and 2008, in which you can see how the rates of antifungal resistance in Aspergillus fumigatus, which is the main etiological agent of aspergillosis, have been increasing. Here is also a nice review in which you can see how this Aspergillus resistant, Aspergillus fumigatus resistant specifically, is in all continents. You can see what is red. It's the environmental isolates have been also reported. And in different levels of blue, you can see the rates of resistance. These are mainly linked with mutations in a specific part of the gene, but there are also some species, some strains of Aspergillus fumigatus that can be resistant to antifungals and don't have these specific mutations that I was describing before. So in one hand, we have Aspergillus fumigatus, which is developing secondary resistance to antifungals, to add to that list of epidemiological threats or threats in the changing epidemiology. And in the other hand is that we learned that the Aspergillus in general, Aspergillus classically, we were saying that Aspergillus fumigatus, flavus, niger, and terreus were the most frequent cases of aspergillosis. And we learned with the use of molecular tools that actually these are complex of a species. So it's not only one species. You can see here section fumigati or Aspergillus fumigatus complex, which encloses several species which are very similar. And in this paper that was probably raising the problem, so that you can see on the left Aspergillus fumigatus colony, typically one, and on the right the Aspergillus lentulus, which is a bit whitey and it grows slower. But believe me, if you see in the lab, there are many times that you can see a patient with Aspergillus fumigatus, which is treated on the antifungals. If you see the strain can be perfectly like this. So these are called cryptic species of Aspergillus. They have been reported in different studies as being around 10% of the total numbers of Aspergillus. And the problem here as well is that they are intrinsically more resistant to antifungals, specifically the section fumigati and Aspergillus lentulus, which is here, has higher MICs to azoles and amphotericin B as well. So these are the two problems in Aspergillus. In one hand, azole-resistant Aspergillus fumigatus raising in some parts It's yes, between 5 to 10%. And on the other hand, some isolates that are intrinsically resistant that look like fumigatus but are not fumigatus but cryptic species. And just, I don't want to take a lot of your time, but I think it's important to also highlight some of the emerging pathogens, which have been emerging for many years, I would say, but probably as we are getting better tools and we are also having better people trained in detecting these species, we are seeing lots of other fungal infections. Here, I just want you to show, for those of you that don't work in mycology, I always say, like, wouldn't you like to work with these guys all your life? Look how beautiful they are. Look at these pictures. So these mucorales or mucormycosis can cause a very broad range of infections. And you can see here how beautiful they are when you find them in the microscope. And these infections can be also, the epidemiology of these infections is very also depends on the country, but also in the type of infection. And you see here the different studies in which you can see how the epidemiology is different from country to country. Which is important about mucorales is that they are intrinsically resistant to voriconazole. So first line treatment for molds, you would also say would be vori. Well, now we have other options, but mainly vori for many years. This guy won't work with mucorales. So very important, if you have a mucorales, it won't work for voriconazole. And then Fusarium is another complex species. Usually it's one of the species that you can get in blood cultures. Usually you can grow Fusarium, and it's very resistant. You probably cannot see much in this screen, and I don't expect you to see it, but it's a lot of species that they are mainly resistant to everything. So voriconazole and amphotericin B are the ones that could work, but they are resistant to all azoles, to candins, and it's very complicated to treat these patients. And finally, Celosporium and Lomentospora prolificans Celosporium, it's also an emerging pathogen that is seen in some places that could be also complicating some infections. Again, you can see here how nice these guys are in the microscope, and also the treatment. It's you can see there is a rare mold guideline that was published in Lancet ID in 2021, in which you can check which are the best agents for these rare mold infections. But you see that voriconazole is the main treatment, combined with terbinafine for Lomentospora or with amphotericin B for Celosporium. Just to finalize, as I was saying, most of these, we don't know what's the main source, but we've seen that there are several things that can be impacting and influencing this changing epidemiology and rise of antifungal resistance. And you can see in this review from that was published a few years ago, in which the use of fungicides in agriculture could pose a threat, but also climate change and changing the risk groups, the biota, the virulence, and many factors are influencing this. So just to conclude, I hope I have conveyed to you that the epidemiology of fungal infection species is changing. It completely depends on the region as well. So there are differences between regions and countries, but also in hosts. So depending on the host you have, the different susceptibility. The antifungal resistance is rising. There is a shift in the epidemiology that of a species causing invasive fungal infections. There are these emerging pathogens as Candida auris or mucorales or Fusarium, but there's also increasing rates of secondary resistance, as we were saying, for Candida parapsilosis, fluconazole resistant, echinocandin resistant, Candida glabrata, and azole resistant Aspergillus fumigatus are also increasing in their rates. So, and the problem is that antifungal resistance surveillance data globally is very scarce, so we don't have very big programs. I think GLAS is including Candida for the first time this year in their call, so hopefully we will have more data. But in the meantime, it's very important that you know your local epidemiology and you know what's your pathogen, how's your epidemiology, to know which antifungal regimen you need to use for your patients. So with that, I would like to thank you for your attention and would be happy to take any questions.
Thank you, Ana. We've got one question from the floor, in fact, a couple of questions from the floor. One of them is that there is no breakpoint for Candida auris. So how do we derive the data on its resistance?
Yeah, there's tentative breakpoints. So CDC developed some breakpoints and they are published, and that's what everybody's using. So the breakpoints developed by CDC, they have not been still included, as far as I know, in UCAS or CLSI, but there are these breakpoints that have been used, that everybody's using to detect this resistance. But it's a very, very good point, and it's, of course, it has to be taken in consideration.
Thank you very much, Ana. Excellent talk. I really like it very much. I would like to ask you, in the list of the WHO, there is, for example, crypto as one of the main pathogens, and other pathogens that we haven't spoken a lot. Could you explain the audience why they are there?
Yeah, I haven't touched in Cryptococcus because I think it's mainly happening in HIV. So there are a lot of infections that is happening, but it's mainly in HIV and in Africa and Latin America. I don't think it's probably in most of our, like in high-income countries, this is not such a big problem, and also because I think antifungal resistance in Cryptococcus is not a problem yet, or at least we haven't investigated that much. So I think, but it's true that it's a real burden. It's one of the critical pathogens, and it's there because this list was mainly focusing on also burden of disease, as you know, HIV has a lot of
Africa, a lot of cases.
Yeah.
Very okay. Thank you very much. Abs, do you have any other question?
Yeah, I was just going to ask about Candida parapsilosis and the rising fluconazole resistance. And, for example, in neonatal ICUs, parapsilosis is very common, and fluconazole is often used because of its penetration into the kidneys, which is a very common source of fungemia. So how do you think this would play out in the actual clinical setting, Anna?
Yeah, that's an interesting and complicated question. I think it's, and from my point of view of what it has been seen in the paper published, and maybe Jesus can also come up with that because they've done a lot of work on that Candida parapsilosis, is that it's actually, it looks like Candida auris. So it's not that the use of fluconazole has made this arrays, but it looks like clones are expanding throughout the hospitals. So you really need to control these clones. As soon as these clones can be controlled, maybe that's and how are we going to deal with this without fluconazole? I think hopefully in the near future we will have new antifungals, hopefully also active against this, that we can use. But I agree with you that it's a bit tricky. But echinocandins look to be still, despite having these higher MICs, they look to be active. They are active against these species. So I think that we have more options there. And yeah, hopefully in the future with the new antifungals coming up, there will be several new options.
Yeah, there is another question for you, Ana. An anonymous someone says, thanks, Ana. Outside Aspergillus fumigatus, are there any data supporting the role of environmental, it has disappeared. Of environmental fungicides as drivers of antifungal resistance in other fungal species?
I think even in Aspergillus fumigatus, that has been investigated for many years already, it's not the like clear evidence. Every time we discuss, we are in panels with EFSA and other societies, they say like, but have you been able to generate this in the lab? No. So in the lab, it has not been generated this specific tandem repeat 34L98H with the use of fungicides. So from my point of view, the problem is that what we are doing, of course, is selecting the isolates with the use of fungicides in agriculture. So it's not that like all this pressure, and it looks like this is in hotspot in a specific basis in which the environment is also having a big thing, like is humid, is hot, you have high levels of fungicides, and then they are selected. So it has been very difficult, even for Aspergillus fumigatus, which is very, very frequent in the environment and everywhere. So maybe there are some studies, I'm not specifically aware of some of them in other species, but it's still, the evidence is like I think is solid enough to say that we are really selecting that in the environment because it's an environmental pathogen. Fungicides are used there, and it's clear that they are cross-resistant to both azoles, fungicides, DMIs, and antifungals. But we'll see. Hopefully, in the future, we will have more data. But yeah.
So we've got a question about more data which is needed from the fungal world, particularly from Africa, and whether it is possible cooperation and work together to create more meaningful data. And I was going to ask the same question, but would somebody else?
Yeah, I completely agree. One of the main problems, we haven't gone through that, but one of the main problems from my point of view in fungal infections is that there is a lack of access to diagnostics. So even in high-income countries, there are many places in which they don't have access to, and there are several diseases for which we don't have a very good diagnostic yet. For example, for Mucorales, we don't have a biomarker. It doesn't work. We have a couple of PCRs. It has very low, even lower sensitivity than other species to in growing culture. So I think we really need to push some countries to increase their armamentarium of diagnostics, but also we need to create awareness and also the people to educate healthcare professionals in this. I think it's a big ask probably because there are many other priorities in their countries, but it's true that I think in the last years there has been some efforts from different initiatives that are improving. There are some data from Africa, so there have been some studies and they have seen high azole-resistant Aspergillus fumigatus in Africa, either environmental and clinical. So we know it's there, it's everywhere. It's only have the appropriate tools and to me to have access to diagnostics, but also antifungals. But because if you only have itraconazole or fluconazole in your country, maybe you don't need to know if it's resistant, because what are you gonna do, right? So I think they need to be hand by hand. We need to push access to diagnostics, access to treatment, and then with that, hopefully we will gather more data. But I think it's clear it's there.
Thank you very much, Ana. It was really brilliant presentation. Now we move to the second speaker, and it's Jesús Guinea. My dear friend Jesús, he will be speaking about detection of antifungal resistance from MICs to SNPs. And Jesús is very close friend of myself, so I would like to introduce him. He's very well known, however. He's a clinical microbiologist at the Clinical Microbiology and Infectious Diseases Department at Gregorio Marañón General Hospital in Madrid, Spain. He has conducted research on medical mycology during many years, with emphasis in the application of molecular biology to the study of invasive fungal infections, to the improved diagnosis of mycoses, and specifically in the last years to the study of antifungal susceptibility of different agents causing mycoses. He received the Young Investigator Award of the European Society of Infectious Diseases and Clinical Microbiology in 2010, so he's still very young. He has been acting as Scientific Secretary of the Steering Committee of the Antifungal Susceptibility Testing Subcommittee of EUCAST since 2016, and he has contributed to the field, co-authoring more than 220 publications in scientific journals with an accumulated impact factor of 1,845 points, and he has a Hirsch index of 45. So it's an honor and a pleasure to have you here at the ISAC webinar, Jesús. Thank you very much.
Thank you, Patricia, for the presentation and for the invitation to participate in this webinar that I think is very, very timely. I think the topic is fantastic and we need to review this in detail. So my presentation is following Ana's, and I'm just focusing on the detection of antifungal resistance. And I will give you some overviews of the specific topics that we have now at the time being, there are, I think that requires more attention than others. So fungal infections are increasing. We know that we've been increasing the number of immunocompromised patients. So along with that, increasing the numbers of patients at risk, we are attending a very high number of invasive fungal infections. But we have to keep in mind that only few species of fungi are able to cause disease. And if you read this nice review by Nathan Witherhold, you would be able to pay attention to those species that are clinically relevant. And some of them have been learning how to become resistant to antifungal agents. So we have a huge problem with these fungi, as we need to treat the patients with a limited number of drugs that we have in the market at the moment. One of the topics have been discussed previously by Ana is the thing remaining with fluconazole resistance in Candida parapsilosis, that I think is one of the topics of the current medical mycology at the moment. So I needed to decide which were the topics or the bullets to be reviewed in my presentations, as the topic was, or the title of my presentation was very wide. So I've specifically selected these three ones. I will have an overview, but the species that require more attention in terms of antifungal resistance detection. I will review something about the methodology. I promise I will not be very specific in this boring part of all these kind of presentations. And we will also review about which kind of samples we need to test in the lab. So I'm going to start out with a very old concept, but that I think still we need to review from time to time. That is the term intrinsic resistance or acquired resistance. In the first part of the slide, there will be a lot of red balls indicating that for a given species and for a given as well drug-back combination, all species or all individuals of the species are going to be resistant. So you just can't infer resistance by identifying the isolates at the species level. But in the opposite, we have the term acquired resistance. That means that the majority of subjects of these species are susceptible, but from time to time, some resistant individuals pop up. So in that case, you are not able to infer susceptibility just by a species identification, and you need to perform antifungal susceptibility testing. Those concepts are summarized in this slide. So when you are facing an intrinsically resistant species, you just can know that it is going to be resistant because you know the species and you know that that drug-back combination is not going to be active. And in this case, it's not worth it to ask for antifungal susceptibility testing to the mycologist, because you know that it's going to be meaningless. In that case, you just need to ask your mycologist to perform a correct and accurate species identification, and that's enough. You don't need to know the profile of antifungal susceptibility. On the other hand, you need to know what is going on when you have a purportedly susceptible species. In this case, almost the majority of the individuals in this species are susceptible. You cannot say for sure that all of them are susceptible without testing antifungal susceptibility. So in these cases, it is important because you need to know how resistant the isolate is to make clinical decisions at that point. And in that case, you need to ask the mycologist not only for the species identification, but also to perform antifungal susceptibility testing. Some examples of intrinsic resistance, for example, Candida krusei or Candida auris, are mostly resistant to fluconazole. The known Candida gist-causing candidemia are mostly echinocandin resistant, and we have molds that are completely resistant to fluconazole. The mucorales, Ana said, they are completely resistant to voriconazole, and the rare species such as Aspergillus tereus or Scedosporium Apiospermum are amphotericin B resistant as well. So when you know that the species identification, you can infer resistance to those agents. So let's have a look at this graph in which we are facing all the drug-back combinations that we will have in the clinical setting when we are facing a patient with candidemia. So we have some combinations that are not allowed, for example, Candida lusitaniae and amphotericin B, or Candida krusei and fluconazole. But in the majority of cases, we have green boxes or orange boxes in which you can treat the patient with that with that agent in question. But sometimes you need to perform antifungal susceptibility testing to make sure that the green box is still green. For molds, we have more red boxes because we have more problems with resistance, intrinsic resistance in many cases for the cryptic species of Aspergillus, or even the increasing resistance to azoles in Aspergillus fumigator sensu stricto. So if you put both figures together, I would like to draw your attention to the green boxes, because they indicate drug-back combinations in which you can have from time to time acquired resistance. So these are the cases in which you have to ask your mycologist to perform antifungal susceptibility testing. And the majority of cases, we infer susceptibility or resistance by measuring the MIC, that is defined as the minimum antifungal concentration able to arrest fungal growth. And molecular biology is helping us out in terms of detecting some SNPs that are correlated to antifungal resistance. Some of the examples are, for example, the sequencing of the FKS gene in Candida glabrata to detect echinocandin resistance. So we need to know how the agents work in order to understand or to gain valuable insight into the mechanisms of action of this of resistance, I would say, in these cases. So when you know where the gene lies, the resistance, you can infer also which mutations can be correlated to the presence of that mutation. So from time to time, when these species are replicating the genome, they can perform mistakes and they misplace nucleotides. And if this wrong nucleotide confers resistance to antifungal agents, it is because the antifungal drug achieves in low concentration to the cytoplasm. Sometimes these mutations confer a different structure of the protein, so the drug target binding is impaired. And in some of the cases, you can have multiple copies of the target, as happened in the TR34 promoter tandem repeat in Aspergillus fumigatus. That means that you don't have enough drug molecules to arrest the antifungal or the fungal physiology. So I think we have many threats at the moment, but I've selected these 4 ones. I'm not going to take any more time on Candida auris. Ana spent some time of her presentation on that. So I'm just hoping to review some data about the echinocandin resistance in Candida glabrata, the spread of fluconazole-resistant Candida parapsilosis, and the problem of the emergence of azole resistant in Aspergillus fumigatus. So we have a problem with Candida glabrata. I would say that it's not a big issue in terms of the number of patients affected, but when you have problems with echinocandin resistance in Candida glabrata, you have an issue there, because these species is intrinsically less susceptible to azoles compared to the other Candida species. So a species in which the treatment with azoles is impaired, you cannot afford losing the echinocandins in these cases. So from time to time, we are attending patients in which the resistance to echinocandins emerge, and it is because the isolates are able to gain mutations in the FKS target genes, as I discussed previously. We have nice papers indicating that this is not a universal problem. It happens in specific hospitals in the States and in Northern Europe. We don't have a big issue concerning this in Spain or in Madrid, in which the majority of isolates are almost free of this problem. But the more cases of Candida glabrata you have, the more higher is the probability of getting that problems. And we know well where the antifungal resistance to echinocandins lies, and some genes are very well spotted, and we can look for mutations in the clinical lab, not only by testing the MIC, but also sequencing the FGS genes of these species. We have a big issue now at the moment with Candida propsilosis. Anna said, I'm not going to overlap the presentation. We have different mutations conferring fluconazole resistance, but the one that is at the moment gaining a lot of attention is that one, the Y132F substitution. That substitution, we don't really know why, but it's quite related to the presence of clones spreading all over the place. And we've been reporting different studies from all over the world in which we were able to spot clones of Candida propsilosis and showing resistance to fluconazole and spreading and causing huge outbreaks in hospital. And the last country getting into that list is Spain, with a hospital affected in the Balearic Island. But at the moment, we have a big problem as well in the center of the country, with the capital becoming the hotspot of the issue at the moment. So we have also problems with azoles and Aspergillus fumigatus, as Anna said in her presentation. I think the most interesting thing here is that we are creating the monster in the environment, and the patients are just inhaling already resistant isolates from the environment, from the wild, and they just inhale the resistant isolates, and the azole treatment selects what the resistant Conidia and the patients obviously have a quite poor outcome when they are treated with azoles. We have an issue here in Spain. We've been conducting different studies, and the last study was conducted in 2022 and reported in a meeting last year, and we have a steady rate of resistance around 5%. So it looks like we have a systemic problem here in Spain in different surveys conducted all over the years, and showing a quite steady rate of resistance. And we have also problems with the rare species of Candida. Sometimes we don't really know which is the best treatment to offer to the patients, because these rare species have very low evidence in terms of clinical information, and they are featured by showing resistance to many different drugs. A good example is Candida guillermondi. That species is showing resistance to azoles and to echinocandins as well. So we have limited options to treat the patients. But the good news is probably that with these species are gaining intrinsic resistance, it takes up the fitness of the species is not completely okay. So it takes a toll when they have to acquire that intrinsic resistance. When you compare the outcome of patients infected by Candida guillermondi compared to Candida albicans, the patients had a very good outcome, shown in the graph. So we have different methods to detect antifungal resistance. Of course, I have to recommend the standardized methods, but I'm aware that they are quite difficult to implement in the clinical routine. So CLSI and UCAS are very nice method, but they are sometimes cumbersome, and you need trained people in the lab to carry them out. So probably the most realistic approach is to go for the marketed methods, and we have the sensititer, the e-test, and Vitek as well. And MALDI in some studies have been put into trial for the detection of antifungal resistance, but at the moment I cannot recommend that method yet. So we have to be careful with the marketed systems, because in many cases they've been not completely well validated. A good example of this is this study that was taken or conducted 10 years back. And this group of American colleagues showed us how the rate of intermediate to caspofungin in Candida glabrata was observed when sensititer was used. So that is some probably a consequence of the CLSA breakpoint for caspofungin. But sensititer, we have to keep in mind that sometimes we are going to report I for caspofungin and S for anidulafungin and mycofungin, and that's simply an artifact. It doesn't mean that the isolates are caspofungin not completely susceptible. So this is something to keep in mind when you are testing sensititer in your clinical settings. If you compare with the standardized methods, they are not perfect, and sensititer is not completely okay detecting mutants. From time to time, you're going to miss some FKS mutants for the 3 candidates. So again, susceptible, completely susceptible by sensititer doesn't really mean that is FKS wild type. And again, we have to keep in mind that when we use the e-test that is quite popular in the clinical setting, you have to be careful with the breakpoints, because if you cannot use the breakpoints obtained by UCAS or CLSI when you want to interpret the MIC obtained by e-test. And that's a very nice example reported by Mike and Aaron Drupp a few years back, in which she showed that the use of EUCAS breakpoints to interpret the e-test MICs can be or can guide you to misclassification of isolates in a very high proportion of isolates, probably when it comes to Candida glabrata or Candida krusei. But the e-tests are there, and we all use them in the clinical setting, and we've been working in my lab in testing the performance of the e-test on direct blood cultures when the bottle is tagged as positive or flagged as positive as Bactec system. You can perform directly the e-test on the broth, and it works very nicely, and is quite nicely correlated with the standardized method as well. So we have methods now to detect rapidly these isolates in the clinical settings. We've been working in engineering a PCR to detect the Y132F mutation on pure cultured isolates in our lab. This study is under review at the moment, and we hope it is very soon out there, and you will be able to conduct that kind of detections in your own lab, because we engineered the PCR for a real-time format and a conventional one, and it worked very nicely. 100% of specificity and sensitivity in terms of detecting that isolate. That actually is what means in Candida parapsilosis and fluconazole resistance, because you need to tag that isolates in order to stop spreading or further spreading in the hospital. We have also methods to detect azole resistance in Aspergillus fumigatus. The azole containing agar method is very easy to perform in the lab, and the performance is fantastic. Even though if you are not very orthodox in terms of preparing an inoculum following the UCAS recommendation, you just need to perform a conidia suspension, and that conidia suspension can be roughly stroked on the agar plate, and the performance is completely unaffected by that way of preparing the conidia suspension. So around 100% sensitivity and almost 100% specificity values as well. So I recommend that kind of an approach in the clinical setting. But again, if you are going for the e-test, you have to be careful with the interpretation of the MICs, because even you are performing a very good interpretation of the MIC on the strip, the plastic strip of the plate. The interpretation of the MIC should not be performed using the UCAS breakpoints. They've been depicted by blue line, and this blue line is dissecting the mutant population. So you are going to classify as susceptible isolates that actually are not. So be careful with that. And I refer to these papers we've been conducting in our lab, in which you will be able to find specific MIC cutoff values to interpret the test MICs. We have marketed molecular procedures to detect azole resistance in Aspergillus. I think that the most popular one at the moment is the prognostic PCR, in which you will be able to detect different species of Aspergillus, and in some cases also the most prevalent mechanism of resistance found in the Netherlands and in the north of Europe. There is the presence of some specific point mutations alongside the tandem repeat. So this PCR has been standardized to be conducted or to be performed on BAL samples and respiratory tract samples as well. And I think it was okay that the problem is probably the price. And if you're wealthy enough in your hospital, I think that it would be a very nice approach to determine or detect antifungal resistance in Aspergillus. What samples are important to test? In case of Candida, I think that the blood culture is out of doubt, is out of the debate. You need to perform antifungal susceptibility testing in blood cultures, particularly at the very beginning of the diagnosis of the infection. But you have to keep in mind that other samples are important as well. And abdominal candidosis is another clinical presentation of candidosis. It's not as frequent as candidemia is, but the patients have a poor prognosis sometimes, and the abdominal cavity has been tagged as well as a reservoir of echinocandin resistance. We have different studies showing that. So my recommendation is to test what is going on the intra-abdominal isolates, particularly at the very beginning of the treatment. And we found that when the isolate is susceptible, you should not give up, and you have to look for resistance even though the first isolate is susceptible, because we found that the rate of antifungal resistance when it comes to echinocandins particularly was very high when you tested the sequential isolates as well. So if you just test the first isolate, you will miss around 60% of resistance in patients with intra-abdominal infections. So be careful with that, and don't sleep calmly if the patient has a susceptible isolate at the very beginning of the infection, because the patients can promote antifungal resistance. That's very well illustrated in this paper. With the previous use of antifungals, if you have a look at the graph, you will see that the majority of patients infected by echinocandin-resistant isolates had previously received echinocandins or were in the middle of the treatment with that drug. So that can be an issue in patients receiving antifungal drugs with candins, particularly. Even though the blood isolates are susceptible, don't miss resistance in the intra-abdominal cavity as well. So that's my last presentation. I don't want to lose much time, and I just have a few messages to take home. I think that you have to ask for species identification first, because sometimes if the species are not correctly identified, it's very difficult to interpret the antifungal susceptibility testing. So you have to perform that, but after you're sure that the species identification is okay. So once you have done that, you have to keep in mind that in some cases antifungal susceptibility testing should be a must, particularly in those cases or species in which they are prone to acquire resistance, when you have to or you need guidance in terms of antifungal treatment, and when you have different or new drugs, new species, and you need to know what's going on. Sometimes the methodology should be tailored to the specific necessities or facilities we are working on. And of course, blood is important, but do not miss resistance in other samples, such as the intra-abdominal cavity, particularly when you have a first isolate tagged as susceptible. And that's all, folk. I will be happy to discuss with you some questions. Thank you.
Thank you very much, Jesus. Excellent talk. And Jesus, moving to the questions, one colleague from Vietnam asked, which is the method that you would recommend to screen resistance in lower income countries?
In the case of Aspergillus, I think that the acyl-containing agar plates is fantastic. I think it's quite easy to perform, is very cheap, and the interpretation of the results is very straightforward. So I would go for that in the case of Aspergillus fumigatus. For Candida, I think CLSI has some procedures to screen for resistance with discs containing acyls, fluconazole, probably.
Okay.
I think you can use an e-test for Candida glabrata and echinocandins. Just one echinocandin is fine, and idurlafungin would be the recommended one. I know that it's not cheap, but it's not very expensive if you just use one strip.
But it was worrying the problem with the MICs. So in which way would you be confused? You will say something that is not susceptible is susceptible, or the other way around?
Well, the thing is that when you're not able to conduct a reference method and you have a patient that is not responding well, and the results are not matching the susceptibility report, I think you should resort to a referral lab if you are not able to conduct that in your lab. Because sometimes you can have a sensitizer showing susceptibility in an isolate that is actually an FKS mutant. It's not common, but it can happen. And if you are not close to a referral center, you need to know what's going on there. But I think
with a test,
with a test, I think with a test is okay. But the thing is, sometimes the interpretation of the MICs can be tricky, because the inserts of the e-test do not give you specific recommendations about the interpretation of the MICs. And the thing is that if you choose the breakpoints from CLSI or UCAS, you can have that kind of problems. Okay. So I think that the manufacturers should invest some money and try to validate their methods first.
Okay. Abs, do you want to ask Jesus some of the questions we have here?
Yeah, there are many questions from the floors, and one of them that I've picked up is this Y132F mutant, and why is it so successful, and is there a selective evolutionary advantage?
Well, the thing is that's very, I think is a wonderful piece of science that isolates acquiring that mutation. I don't know why these isolates are not impaired in terms of virulence or the ability to perform or to create infections. So they are quite fit in terms of creating infections are as well. They are resistant. So I don't have any specific theory for that. But
do they produce more biofilm or more biomass? They are more sticky, or what's the problem?
With Aspergillus now, they do not really create biofilms very often in the environment. Yeah. I don't think it is a problem of losing fitness in these isolates. And probably over time the proportion of cases caused by azole-resistant Aspergillus fumigatus isolates is going to go up, because the isolates are not impaired in terms of virulence, and they have the advantage of resistance. So that can be an issue in the future.
And Sophie Fremiot also asked about Candida parapsilosis. And she asked if you know if they can be resistant to disinfection preparations in the environment in the hospital. And I was thinking about this kind of Candida when I ask you if they are producing more biofilm or more biomass. Why do they stay in the hospital so well?
I don't really know. I don't have an answer for that. I think it's an enigma at the moment. Some previous studies have shown that the biofilm formation in these isolates is very poor, at least in using the methodology used in the lab. Probably in the environment, these isolates can form biofilm that cannot be measured using our tools. But using the typical way of preparing biofilms and measuring the thickness of the biofilm, they are not very very good biofilm formers. So I don't have an answer to.
And do you know if they are resistant to the disinfectants as Candida auris, or?
I think that the data is very scarce. I wouldn't say that. I don't know.
Abs?
Yeah, just one more question, I think, from the floor, which is in relation to the fact that we don't have many SOPs to deal with complicated cases. We've got a lot of information, but no guideline. And that's something that we all moan about very often.
So what's specifically the question?
Is that we don't have SOPs or guidelines to treat actual complicated cases, which is something.
Yeah, that's always a problem in mycology. We have rare species and we don't have clinical evidence to support some kind of recommendations, and that, I think it is just art. And sometimes we need to gather information, antifungal susceptibility testing, experience with cases infected by that, because sometimes, you know, the results are a bit unexpected. With Candida guillermondi, I showed you that it's very resistant, but the patients are doing very well, probably because this species is not very virulent compared to Candida albicans. So sometimes it is like that.
Okay. Thank you very much, Jesus. Thank
My
you.
pleasure.
It's my pleasure to introduce Dr. Antonio Vena, who is an ID consultant, infectious disease consultant, and member of the Antimicrobial Stewardship Team at the IRCCS San Martino Hospital in Italy, in Genoa. From 2013 to 2017, Antonio worked as a clinical researcher and infectious disease consultant at the Department of Clinical Microbiology and Infectious Diseases. Since 2019, he has been a member of the European study groups of infections in the immunocompromised hosts and European study groups of fungal infections. Antonio is here to talk on the clinical impact. It brings us very nicely into how all this impacts clinical medicine in general and patients with fungal infections. And Antonio is also going to give us some insight about the options for managing resistant fungi, particularly the newer drugs. Over to you, Antonio.
So today I will talk to you about the clinical impact, a new therapeutic option for managing antifungal resistant fungi. So here you have my disclosure, and I would like to start my lecture from this review article that we published some years ago together with Patricia Munoz. So in this article, we tried to assess the issue of antifungal resistance and its impact on the clinical outcome of our patients. And at the end of this review, we summarized our feeling with the following sentences. Although antifungal resistance has been associated with a poorer response to antifungal therapy in various studies, other factors such as comorbidities, septic shock, and source of infection appear to be key determinants affecting the clinical outcome of patients with invasive fungal infection. So the problem of at that time is that we included in this review only studies with very few prevalence or with a low prevalence of antifungal resistance. In all the studies that we were able to include in such review, the prevalence of resistance to azole did not reach 10%, and the resistance to echinocandidates was also very low, below the 3%. But as Ana and Jesus showed you before, the world is now changing, and unfortunately, antifungal resistance is increasing, and it's mainly increasing in some geographical areas, and it is probably driven by the use of antifungals as well as the spread of resistant clones. So from a clinical point of view, I think that the real challenge that we have today regards Candida auris and azole-resistant Candida parapsilosis in terms of yeast infection, whereas for Aspergillus, I think that the problem that we today face is related to infection due to azole-resistant Aspergillus fumigatus or a cryptic species. So I will try to focus my talk on this species. So regarding Candida auris, as you know, Candida auris has been described for the first time in 2009, and since then we have different outbreaks described in different countries. As you can see in this map, for example, the outbreak that we have in the United States, as well as the outbreak in the United Kingdom. And in order to understand the importance from a clinical point of view of the Candida auris, I show you the fungal susceptibility of Candida auris at my hospital. For example, at my hospital, the resistance to azoles is about 100%, and about 1/2 of our strains are also resistant to 1,4-3b. This resistance to echinocandidates is low, but we have 2-3% of the patients that show a resistance to echinocandidates. And as you know, Candida auris has been traditionally associated with higher mortality rates. But regarding this topic, I would like to present you this interesting study in which the authors wanted to compare the clinical characteristics and outcomes between patients with bloodstream infection caused by Candida auris and those with bloodstream infection due to other Candida species. So in this study, they included a large number of patients, about 80 patients with Candida auris bloodstream infection. And Candida auris patients with Candida auris bloodstream infection were more frequently admitted from nursing home at a longer length of hospital stay, and were more frequently affected by COPD, dementia, and a prior history of antibiotics. But when the authors analyze the impact in terms of mortality, they were not able to demonstrate any differences in terms of mortality between groups, neither in 30-day mortality rate, in hospital mortality rate, nor 90-day mortality rate, nor 14-day clinical failure. However, patients who had a bloodstream infection caused by Candida auris had a higher percentage of recurrent bloodstream infection during the following 60 days. And the problem of mortality related to Candida auris has been also addressed by other colleagues. And in all the paper that you can see in this slide, the mortality due to Candida auris was not higher in comparison to other Candida species. Another important pathogens, I think, that is the AIDS-resistant Candida parapsilosis. Here again, I show you the maps regarding all the countries that are affected by the problem of AIDS-resistant in Candida parapsilosis. As you can see, there are some areas in which the prevalence of fluconazole resistance in Candida parapsilosis has been described up to 40% of the cases. And according to this nice review recently published on Lancet, the authors suggest that patients with fluconazole resistant Candida parapsilosis have a higher mortality rate in comparison to patients with fluconazole susceptible strain. However, if we look at the studies addressing this issue, the mortality related to fluconazole resistant Candida parapsilosis does not seem to be higher in comparison to fluconazole susceptible Candida parapsilosis. For example, here you have a study from Spain in which there are very few patients. There are 15 patients with fluconazole resistant Candida parapsilosis, but look at the mortality. No differences between groups. And also, there was no differences when the authors analyzed the mortality attributable to candidemia. This is just, I would like to share my experience, our experience with Candida parapsilosis fluconazole resistance. So here you have the episodes of candidemia due to Candida parapsilosis at my hospital. So here you have with the yellow bar, the overall number of patients with Candida parapsilosis detected at my hospital every trimesters, and with the red line, I show you the percentage of fluconazole resistance. So as you can see, at my hospital, we have up to 70% of Candida parapsilosis showing resistance to fluconazole. So we have tried to assess the issue of the impact of fluconazole resistant in terms of mortality in patients with candidemia due to Candida parapsilosis. So this is the first time that I show you the results of this paper that it is currently in the process of being written. So we performed a multi-center retrospective study, including patients from Madrid, patients from Genoa, and patients from Pisa, in which we wanted to compare the mortality in patients with fluconazole susceptible versus fluconazole resistant Candida parapsilosis fungemia. So we included a large number of patients with fungemia caused by Candida parapsilosis. I think that this is the largest database analyzed so far regarding this topic. And look, at our hospital, we had 40% of candidemia due to Candida parapsilosis that showed resistance to fluconazole. All of these patients were treated and properly treated with echinocandins as definitive therapy, whereas regarding patients with fluconazole susceptible Candida parapsilosis, about half of the patients received fluconazole and half echinocandins. When we analyze the survival rate, here you have one of the main findings of our paper. Basically, there was no significant differences between groups. We also performed a multivariable analysis, and here you have in green the variables associated with mortality, age, solid neoplasms, underlying disease, antifungal use in the prior months, as well as septic shock and source control, were all factors associated with mortality. But in our study, having an infection due to fluconazole resistance was not. We also performed a propensity score analysis, in which cases with candidemia due to fluconazole resistant Candida parapsilosis properly treated with echinocandins, whereas controls were subject with fungemia due to fluconazole susceptible Candida parapsilosis receiving fluconazole. And here you can see that the probability of survival was similar between groups, with no differences in terms of clinical outcome. So at the end, we conclude that we were not able to demonstrate any association between mortality and fluconazole resistance in patients with Candida parapsilosis fungemia. Another important aspect is related to Aspergillus. So and we will focus our attention on azole-resistant Aspergillus fumigatus. So here you have, I think, one of the most important paper that has been published so far regarding this topic. So this was a retrospective cohort study in which the authors wanted to compare the mortality of patients with voriconazole susceptible and voriconazole resistant invasive aspergillosis. So in this study, they only included patients with culture positive invasive aspergillosis, and the prevalence of voriconazole resistant was 20%. So in this study, the authors showed lower probability of survival in patients who had a voriconazole resistant strains. So here, probably, I am not so sure that the lower probability of survival was related to voriconazole resistance per se. This is because in this study, the time required for the detection of voriconazole was about 10 days. And I think that is something that generally occurs in all of our hospital, or at least in many of our hospitals. Supporting this sentence, I present the results of one of the most interesting study that has been published the last year regarding this topic. In this study, the authors wanted to analyze the impact of an azole-resistant PCR in the outcome, in the management of patients with invasive aspergillosis. So in this study, they included only patients with hematological disease, who had a clinical suspicion of invasive aspergillosis, and they also had a bronchoalveolar lavage fluid available for PCR detection. So look at the results. Large number of patients with clinical suspicion of invasive aspergillosis. The Aspergillus fumigatus DNA was positive in about 1/3 of the patients. And when they performed the resistance PCR, it gave conclusive results only in 65% of the cases. But when it was conclusive, it was able to detect the mutation in about 15% of the cases. 8 patients as absolute number. 2 patients were excluded because they had mixed susceptible resistance infection. But look at the results, at the main results. when they analyzed the 6 patients with resistant strain, just 1 out of 6 patients had failure to treatment, and the percentage is lower than the percentage reported in an historical cohort in which antifungal failure was observed in about 70% of the patients. In this study, the authors wanted also to analyze the outcomes of the different mycological tests in terms of mortality, and they observed that a positive galactomannan was associated with a higher risk for mortality, whereas an isolated Aspergillus PCR was not. So at the end of this paper, they suggest that PCR-based resistance may help to limit the impact of AIDS resistance. And what about the new antifungals? So I think that before talking about new antifungals, we do not have to forget the basics. I mean that when we have to manage patients with invasive fungal infection, we have always to consider before administering the antifungal treatment an adequate SUS control, as well as, for example, the removal of infected devices. We have to think about PK/PD. I mean, we have to ensure getting the adequate dosage of the drug at the site of the infection, and we have also to rule out the disseminated disease. So these are general rules that should be followed for all patients with invasive fungal infection, but in my opinion, they are more important, they are even more important for patients with antifungal resistance infections. So regarding the future, well, this is a very nice table that was published by Martin Oengel some years ago. And as you can see, the antifungal pipeline looks great. So we should have in the future several new drugs active against Candida, including Candida auris. And all of these drugs, except for a lot of them, are active against Candida. So this is an in vitro studies. This is a systematic review in which the authors included 26 studies, and the authors wanted to analyze the in vitro activity of all such new drugs against Candida species, including Candida auris. And as you can see, all the new drugs, fosmanogepix, ibrexafungerp, as well as redzafangin, were all active against Candida auris. Regarding redzafangin, as you know, redzafangin has been studied in 2 different randomized controlled trials, the STRIVE and the RESTORE trial, in comparison to caspofungin for the management of patients with invasive candidiasis and candidemia. So basically the RESTORE trial demonstrates the non-inferiority of redzafangin in comparison to caspofungin, but what I think that is the good of this drug can be understood by looking at this figure. Patients receiving treatment with redzafangin at a higher rate of mycological eradication at day 5. So redzafangin was able to eradicate faster the Candida from the blood than caspofungin. And I think that it can be very useful in the management of some patients with multi-drug resistance infections. Another important drug is the ibrexafungerp. I think that ibrexafungerp probably is the drug for which we have more data in the management of difficult to treat infection. Here you have the results of the CARE study in which the drug was administered for patients with invasive candidiasis caused by Candida auris, whereas on the right, we have the main result of the FURI study in which patients with invasive fungal infection, refractory or intolerant to standard of care were included. So in both studies, the drug showed to be effective in the management of these patients. And also we have the fosmanogepix. This is also a drug with a new mechanism of action. We have two different phase 2 clinical trials. The first one, the drug was evaluated for patients with candidemia caused by Candida auris, and the primary endpoint of this in this study, the treatment success at the end of study drug was observed in 90% of the patients, and similar results were also obtained in this other study, in which patients with candidemia caused by other Candida species were included. Here again, 80% of clinical success. The drug is currently available through compassionate use program. I don't know how simple will be to obtain the drug, but remember that if you need, the drug is currently available for your patient. And regarding Aspergillus, here again, we have several new drugs. I will mainly focus on olorofim and opelconazole. Olorofim is a new drug with new mechanism of action. It is not a wide spectrum antifungal because it has no activity against yeast or mucorales, but yes, a strong activity against Aspergillus, including azole-resistant Aspergillus fumigatus, as well as cryptic species, and it has also good activity against other molds infection. So regarding clinical data, I show you the results of this phase 2 trial in which patients with invasive molds, refractory, resistant, or intolerance were included. Here, there are 200 patients enrolled, but I show you the results of the subgroup of patients with invasive aspergillosis. So day 42, the overall complete partial response was observed in 35% of the patients with a mortality rate of 25%. And as you know, the drug is also being under investigation in comparison to liposomal amphotericin B, followed by standard of care for patients with invasive aspergillosis refractory to mild active azole therapy with proven resistance, or who developed the infection during active molds prophylaxis, or who have azole drug-drug interactions. But the results of this trial are not yet available. Just one slide regarding the opelconazole. This is because I think that opelconazole is quite interesting, as it is the first in-class inhaled antifungal triazole with a good spectrum of activity. The advantage of this drug is related to its route of administration, and that probably enable a high concentration of the drugs into the lung. And there are currently 2 different studies using opelconazole, one regarding invasive aspergillosis, the treatment of patients with diagnosis of invasive aspergillosis, and the second one focus on the prophylaxis preemptive therapy of invasive aspergillosis in lung transplant. So just to conclude, how I think the future will be. So, I mean, today we have, for the patients with invasive candidiasis caused by azole-resistant Candida species, we can only use echinocandins or amphotericin B, but probably in the future we can also use benzafangin, imbrexafanger, or fosmanogepix. For patients with invasive candidiasis caused by echinocandin-resistant Candida species, today we have amphotericin B, but probably in the future we can also use imbrexafanger or fosmanogepix. And for patients who who have invasive aspergillosis caused by azote resistance. Today, I think that the cornerstone of treatment is liposomal amphotericin B, but probably in the future we can also use olorofim or opelconazole or probably brexafungel for fosmanogepix. So to conclude, what is the clinical impact of antifungal resistance? So according to the results of the studies that I show you, I think that when patients receive proper antifungal therapy active in vitro, invasive fungal infection due to antifungal resistant strains do not appear to be associated with an increased risk of mortality. However, resistance, I think that could have a significant impact in terms of recurrence of infection, as I showed you for the case of Candida auris, but also in terms of empirical therapeutic choice in a given hospital setting. For example, if my hospital is not possible to administer fluconazole as empirical therapy. Although I have shown no data, probably the antifungal resistance may be associated with an increase in cost, with side effects or drug-drug interaction, as well as a longer length of hospital stay. This is because we lack of oral medications. So for this reason, we need new antifungals, and I think that we have very interesting new entries with better spectrum, reduced toxicity, less drug-drug interaction, and the more convenient route of administration. But please be cautious, be having a cautious enthusiasm, because there are very few phase 3 studies and no phase 4 study at all. Thank you very much.
Thank you very much, Antonio, for this very insightful presentation, and also for giving us the first notice of the results of the Candida parapsilosis study. We are the first to have seen that data, so we are lucky. It's very interesting that the mortality was not higher, as some authors have mentioned. Yeah.
I wanted to come on that point, Patricia and Antonio. I saw that slide that you showed, the fluconazole sensitive Candida parapsilosis and its mortality compared to the mortality with fluconazole resistant Candida parapsilosis. But from what I understood, fluconazole resistant isolates, the patients with fluconazole resistant isolates were treated with echinocandins. So in that sense, it's a comparison between two groups which were adequately treated or optimally treated. But do we have data about treatment of fluconazole resistant Candida parapsilosis with fluconazole until you found out that it was resistant?
Yeah, but I think that it was very short time, no? And probably you do not start with fluconazole in your hospital.
Yeah, yes. This is the issue. In our hospital, we cannot administering fluconazole as initial antifungal therapy for these patients. There were just few patients who received initial antifungal therapy with fluconazole, but it was for a very short period of time. It was just 2 days, and later they received other antifungal treatment, mainly echinocandins. So this patient, we decided to analyze just the targeted antifungal therapy. So we decided to include patients who received treatment as definitive therapy. So I did not remember exactly how the patients received fluconazole, how was their clinical evolution, but I think that if I remember well, all of these patients were switched to amphotericin B or echinocandins within a few days.
Okay. Ana, do you have your hand up on purpose? Yes.
Thank you, Patricia. Yes, I just wanted to comment on this because I think it's very important. In one hand is that you are dealing with the first line treatment is an echinocandin in Candida, so it's a bit tricky because of course that won't be, but in low and middle income countries, as we see, there are a lot of people that comes from other countries. There is an issue because they don't have echinocandin, so probably they will be treated with fluconazole. And also you are taking into account hospitals that do have very good access to antifungal susceptibility testing. So I think it's important to convey the message that as long as you have these things, no? So you are treating first line with an echinocandin. You're comparing patients that have been treated with the appropriate, because you have susceptibility testing very quick. Then that's it. And on the other hand, the one that you said about azole-resistant Aspergillus fumigatus, only one patient, but out of 6. So I think, and you said that already, but I think the problem here is that, in the best case scenario, when we have everything available fast and quick and the best, this works. But reality is far from this. And we need to convey this message. It's so important to do susceptibility testing, to gather epidemiological data. Even if you don't have it in place, if you know your local epidemiology, then you can try to change. And again, I think like access to antifungals is also very limited. So I think that I wanted to highlight that.
You are completely right. People should at least keep their isolates, so afterwards they can be analyzed elsewhere. And I hope that the new antifungals are not very expensive, so everybody has the possibility to use them, because otherwise it's going to be crazy. You have those very nice drugs there, and we are not going to be able to use them if they are very expensive.
But Patricia, even take into account that caspofungin, none of the candins are available in Latin America, for example, even if they are low. Yeah, really. It's, or maybe there are some colleagues that they comment, but it's very limited. So even these new antifungals, we are focusing on our world in high-income countries, but reality and where fungal infections are really happening are in places in which they have fluconazole. And
we mentioned the crypto, but
but
probably other fungi as well. Abs, do you have some?
Yeah, I've got another question, if you don't mind. Antonio, it almost seems we are spoiled for choices with so many new antifungals coming, but of course we have to be cognizant of the fact that resistance can develop anytime. Still, how do you see these agents kind of sometimes competing with each other for a place in the guidelines or in the hospital formulary? For example, Ibrexafunga versus fosmanogepix?
Sorry, but I have a problem with the connection, and I did not listen to your...
Antonio, Abs is asking, how do you see these new antifungals, for example, position in your hospital in the future? Because they are like competing. What are you going to recommend? Resa or Ibrexa or fosmanogepix?
I mean, I think that these new drugs can be very useful in order to early discharge some of our patients with very complicated disease, as well as they can be also very useful for the management of patients who need a very long course of antifungal therapy, such as patients with endocarditis, for example. And this is mainly for the management of patients with candidemia, and they also can be useful for step-down therapy. I mean, today, for the management of patients with azole-resistant Candida parapsilosis or Candida auris, we don't have oral drugs that can be administered for these patients, but probably thanks to fosmanogepix or Ibrexafungerp, some of our patients could be also treated at home or even with oral drugs. And also fosmanogepix and Ibrexa could be also useful for the management of some patients with invasive aspergillosis, of course, and fosmanogepix even for the management of other mold infections such as fusariosis or aspergillosis, so on.
Yeah, you see, Abs, that someone from India is saying, Anna, exactly what you mentioned, that they are using fluconazole or Ampho-B for initial therapy and for empirical therapy. So candins now, in at least in my country, they are super cheap because they have lost the how do you say it? No, the patente, the
off license. They're off license.
Off license, yeah, and they are very, very cheap. But yeah. So, do you want to close? We still, yes, Antonio, yes.
No, I would like just to underscore that the first conclusion of my presentation is when adequately treated. I mean, this is I completely agree with the words of Anna and her comments. I think it's I completely agree with her. We need to perform antifungal susceptibility testing, and we have to treat adequately our patients before.
Now that I have, Antonio, now that we have Abhijit, Ana, Jesús, who are so experts, may I ask you if the detection of a mutation is the same as resistance in vivo? They are all moving their heads.
No. You mean, I think there was a question about that in the chat, Patricia, already. So we are not as far as bacteria in some cases. I don't think, maybe for echinocandin resistant candida, we can kind of get that, but for the rest, no. 20% of ASU resistant Aspergillus fumigatus can have no mutation in CYP51. And also we've seen strains that have compensation mutations. So I don't think we are close to a molecular detection of resistance in fungi yet. Okay. And there are many, flood spams and things like that. So we need to investigate a lot in molecular mechanism of resistance and also to understand better how it's that impact. Yeah.
Okay. So if you want to close up, so we have some messages from Fee on the chat. You can all access the chat. Announcing the next webinar that will be on pediatric antibiotic therapy, and also asking you to join us in Istanbul in the meeting. So if you want to close.
Yeah, I was just wanting to summarize, but before that, there's just one question coming up about itraconazole, if somebody wants to take it as to the place of itraconazole. I don't know, Antonio, if you are the best person to speak to.
Can you hear me?
Yeah.
Yeah, I mean, I never used itraconazole for the management of patients with candidiasis, and for patients with aspergillosis, also very few experiences as being.
I used to use it because I'm older. Yeah. As prophylaxis in solid organ transplant recipients, we use itraconazole for prophylaxis before POSA and all that, and we had to be very careful with the interactions. But it's a good drug, of course. You have to be careful and know how to use it, but it's a good drug.
And again, sorry, because in low and middle income countries, that's the main azole they have. So they really use a lot of itraconazole yet. So again, I think and there are also differences between some others, but the reality is that it's very wild used worldwide.
Yeah, sometimes for recalcitrant nail infections, for example, there's a place for it. It's the world of mycology is not just Candida and Aspergillus. And I think there's one more question that's come up. Or is it a comment? I'm just saying, yes, somebody's saying that they're using it in India.
Yes.
So just to summarize, we had excellent speakers today, and thanks to all of you, Ana, Susan, Antonio. We started with the epidemiology, and Ana gave us a overview of that, followed by the laboratory aspects, which I think Jesús covered very well, including the SNPs and other technical issues. And then Antonio just summarized it in terms of its clinical impact. So I think we covered the spectrum of mycology in the three of the talks today, and we had very active participation from several people. I mean, more than 200 people on the chat, and so many interesting questions. So thank you to all our speakers. And not sure if Patricia, you want to add something?
No, thank you very much to everybody. Thank you to the speakers. And during some time we had more than 300 people connected, and the talks will be available in the webpage. Thank you. Bye-bye.
Bye.
Thank you.
Thank you.